problems in Fabry disease. So Fabry disease is one of my favorite topics, and I'm really looking forward to this talk. These are my disclosures. So as you know, Fabry disease is an X-linked lysosomal storage disease. It's secondary to mutations in the GLA gene, which leads to storage of complex lipid molecules. And as that storage accumulates, it damages various organ systems, particularly kidneys, heart, and the nervous system. The impact of Fabry disease is multi-organ and eventually leads to organ failure. And this is just an example of several of the problems that may occur with Fabry disease. There are some severe manifestations. 40 to 60% of adults with Fabry disease will have heart problems. A smaller number, but greatly increased risk of stroke. And then kidney disease, there's a dichotomy between men and women. Things that are not as life-threatening are also important, and particularly GI disease, which affects 60 to 70% of patients, and pain, which is in about the same range. Now, one of the challenges with Fabry disease is that it's a slowly progressive disease. So on this slide, you can see that patients start being symptomatic around age 5 to 10 years old, and often will not be diagnosed until much later, and then will develop additional problems over time. The goal for management of Fabry disease needs to be to start interventions where there's still reversibility and to recognize the earliest signs as efficiently as possible so that we can make informed and not urgent management decisions. Now, there are a lot of nonspecific symptoms in Fabry disease. These include pain, depression, nausea, fatigue, reduced overall quality of life, increased anxiety, and as we will learn in a moment, a significant amount of sleep disturbance. All of these problems appear to be increased in Fabry disease, not only compared to the general population, but also to many of the other chronic diseases that overlap in symptomatology. So to get started on the sleep portion of this, I'm going to give a couple of case reports. First, this is a patient that I've cared for several years. He's a 54-year-old male. He was a former chef, and he has Fabry disease. And because of his Fabry disease, he required a renal transplant many years ago. That kidney failed, and he was on dialysis for approximately 10 years. And then 4 years ago, got a second renal transplant. He has moderate heart disease, but importantly, does not have cardiac arrhythmias. But he came to see me and reported crushing fatigue, overwhelming daytime sleepiness, to the point that he was not even able to do his own basic self-maintenance care, like the shopping, paying the bills, cooking his meals. And he was considering just stopping all medical intervention and basically said he was ready to give up because the quality of his life was so poor. And that got me thinking about, how common is this in the world of Fabry disease? I had another patient. This one was a 17-year-old. He was early in the course of his Fabry disease, and in fact, when I met him at 17, he was not diagnosed. He had no heart disease, no kidney disease on standard measures, but we suspected Fabry disease and tested him. Now, added information, he did have significant pain and had had that for some time. And the pain itself was incapacitating. but responded quite well to treatment with neuroleptic medications. He was failing his classes in school, and when I asked him about that, he said he was just too exhausted to keep up. Turned out that if left to his own devices, he would sleep 18 to 20 hours per day. He would get up for meals, and he went to school because he was forced to, but really didn't do anything else. He also reported just a terrible quality of life. Now, these patients were both male. I have had similar stories from multiple patients starting in high school, going into old age, and both men and women seem to be about equally likely to have this kind of complaints. So I looked into sleep. What has been published on Fabry disease? So this paper, which is not new at this point, but is frequently cited, they had a case report similar to the two descriptions I've given, and then they evaluated a series of patients with Fabry disease. What they found was that about 68% of the patients reported significant daytime sleepiness that interfered with their ability to function. And they also looked at their series of patients for a frequency of other common complaints related to Fabry disease and found that the significant daytime sleepiness was in fact more common than heart dysfunction, kidney disease, angiokeratomas, and even pain. Now, their patient population had an average age of about 43. They also found that incapacitating chronic fatigue, which is slightly different than daytime sleepiness, was present in about half of their patients. They further reported that daytime sleepiness was a major component of lower SF-36 scores, particularly in the physical and mental quality of life area, explaining at least a quarter of the variance in scores. So how do we assess patients? One of the things that needs to be looked at for daytime sleepiness is how is the nighttime sleep. So sleep studies can be used. And this study looked at a series of patients with Fabry disease and found that about a quarter of them had poor quality nighttime sleeping. Of those, about 80% had obstructive apnea and about 20% had some component of central apnea. The amount of obstructive sleep disturbance did not correlate with daytime sleepiness. However, depressive symptoms did correlate with daytime sleepiness. And the amount of daytime sleepiness and the amount of nighttime disordered sleeping tended to increase with age. So that raised a number of questions. This is a more recent study trying to figure out what are the drivers of this disordered sleep. And this group previously had studied it and found that melatonin and related metabolites were abnormal in patients with Fabry disease. In fact, they were flipped compared to the peak melatonin levels being during the day and lower levels at night. Now that did not correlate very well with the amount of sleep disturbance or with the general well-being of the patients, but they found that interesting. And then they looked further into their sleep habits and found that the patients with Fabry disease were much more likely to take naps during the day, and when they did take naps, the naps lasted 42 minutes longer than naps that their control population had. This contributed, they felt, to poor quality of sleep in the day and the night, with many of the patients reporting that while they did sleep, they did not feel rested when they awoke. And this did not correlate in any way with heart disease or kidney disease. Um, so this is another study that looked at sleep disordered breathing, and again, sleep studies were the major measure. And what they found was about 50% of the people had poor quality nighttime sleep, and that 95% had abnormal periodic movements during the sleep, so restless leg syndrome, and that the restless leg syndrome severity correlated with depression and anxiety, but did not correlate with the degree of the disordered sleeping at night. Um, so to me, that so far indicates that we have um, sleep problems are very common and that they are likely driven by neurologic um, issues, and that some of that is a disruption of this typical circadian rhythms. So this is another study. This one was not specifically focused on sleep, but it did assess sleep. And they were looking at neurologic findings in lysosomal storage diseases, and specifically in Fabry disease. What they found was that depression, pain, and sleepiness were all increased, all appeared to be neurologically mediated. However, there was a difference in the pattern in Fabry disease compared to the other lysosomal disorders, because the increasing neurologic signs in the other disorders correlated very strongly with neurologic deterioration and loss of cognitive and functional abilities, where in Fabry disease it did not, but it appeared to be a chronic um, and significant burden that decreased quality of life. So this brings me now to some anecdotal observations that I have had that I think are related to some of the sleep issues. So patients with Fabry disease often develop bradycardia and low blood pressure, especially when they are sleeping. I first found this when we started doing enzyme infusions in my patients, and we would get called with low heart rate and low blood pressure on almost every patient every time we did an infusion, to the point that we had to redefine what constituted a significant abnormality. We also have noted, as have the studies I've mentioned, poor quality of sleep with frequent daytime sleepiness, frequent insomnia at night, and not feeling adequately rested. I also note that many of our patients take other medications, and those medications can, in some cases, also contribute to some of the sleep disturbance. So, where does this take us? So, the big message, I think, is that sleep problems are very common in Fabry disease. We do not know how early they start. We don't know all of the drivers for them, but it seems likely that they start in adolescence, that they continue through adult life, and that they appear to get more severe as the patients age. Sleep disturbance has, for of all people, has implications for health and tends to aggravate things like heart disease and be a contributor to blood pressure problems and other symptoms. It also has a very strong negative impact on quality of life, which makes this an important issue, and particularly important given the greatly increased incidence in people with Fabry disease. There appears to be a correlation with depression and a lack of a correlation with the other major organ involvement, leading me to the conclusion that this is likely neurologic and is not well explained by lung disease or obstructive breathing. I could not find any information on studies of treatment for the sleep disturbance in Fabry disease. So conclusions, again, sleep disturbances and excess daytime sleepiness are very common in male and female patients. This is probably a neurologic manifestation and needs to be approached as in a similar fashion to the other neurologic manifestations of Fabry disease. Current treatments for Fabry disease do not appear to resolve this problem, and I think that trials of stimulant medication during the day are worth considering and have had a little bit of anecdotal experience with that, with some patients successfully treated, including both of the cases that I highlighted in this presentation. I also think that as we develop newer forms of treatment, that studies of the impact of the treatments that get into the nervous system have on sleep are also warranted. And with that, I will stop and would be happy to answer any questions.